Hello guys, hope I'm audible and visible. If some of you online say hi, hello, welcome back once again. So I had left the GIT in the and the hepatobiliary, the part one. The last part we saw about the few hepatobiliary neoplasms. The rest of the GIT is to be left to be dealt with. So we'll be starting with the same. Hello Suresh, as usual. Good evening. So we'll start with the GIT here. Good evening, Osama. Hope you're doing good. Hope your preparation is doing good as well. Fine. Hello, Meet. How are you? So great. So we will start with the GIT part. We had done the liver part in the last part one session, and I'll be completing the GIT part today. Fine. Good evening, Meet. So we'll start with the basic things of I'll be talking about a benign and malignant ulcer. We'll have a quick look on chronic gastritis. We'll have a talk about inflammatory bowel disease, the sprue, the celiac sprue, and the tropical sprue. And also, if time permits, we'll have a quick look at intestinal adenocarcinomas. Right. So these are few things which are required from an maybe an undergraduate point of view. There are lots more things covered in FARRE. I'm going to cover these things which I feel is salient, important for you. And like I said already, if you want any extra class in FARRE, do let me know. I'll definitely do that as well. Good evening, Rajashri. So let's start the today's lecture without any delay. Uh, what is the difference between benign and a malignant ulcer? So this question especially can come as a short answer. It's not just that. It can come in your viva sessions because you must have definitely had the jar specimens of a gastric ulcer, and they might ask you how do you differentiate a benign versus a malignant ulcer, right? So first we look at the theoretical differences, then we'll go to the gross differences, and if at all any microscopic differences also there. Fine. Okay. Now anything, if you differentiate, I want you to start with the history, start with the age, right? Because that is more important for you to give an holistic approach of you are behaving like a doctor and not like a student. Fine. So tell me which of these two ulcers are going to be present in older age, right? It's going to be more of interaction. So I want you to I'll be asking leading questions, and I want you to comment the thing. Obviously, the malignant ulcer will be obviously in an older age person, right? Just yeah. So this will be seen in older age group, and obviously this will be seen in relatively younger age group. So when I say benign ulcer, it can be a H. pylori induced gastric ulcer, it can be a peptic ulcer, whatever it is. Fine. Great, Sada. Fine, perfect. So one is my age, right? So is there any gender predominance? Generally, benign gastric ulcer, one of the important etiology of a benign gastric ulcer is smoking and drink the coffee, all those things is going to result in the peptic ulcer at least, right? Benign ulcer has a little bit of male preponderance, and here also again because of the habit, the alcohol smoking is bit slightly towards a male. Here also has a little bit of male preponderance, but benign ulcer has a very clear male preponderance compared to your malignant gastric ulcer. Fine, okay, great. Second thing, the next thing here, the size. So obviously the malignant ulcer will be bigger in size, that everyone knows, right? So for me, in cutoff size, if I take a cutoff size, so the cutoff size of less than 4 centimeter is something I look for a benign gastric ulcer. Might be 2 or less than 2, but 4 is kept as a cutoff. Anything more than 4 centimeter in size, I generally suspect a malignancy. Again, like I said, it's not a hard and fast rule. A benign ulcer should never reach 4 centimeter, or I cannot have a malignancy which is 1 centimeter. Both can happen, but generally this is the cutoff given, less than 4 centimeter and more than 4 centimeter, right? Okay, one more question. So you know about malignancy, we have read lots of things about malignancy, right? So I have a benign ulcer which is due to an acid. Most of the time it's a peptic ulcer, right? So what do you think will happen to the base of the ulcer? If it's a peptic ulcer, do you think the acid secretion will digest the entire base of the ulcer and make it clear, or you'll have necrotic tissue there? Like I said, it's going to be more of interaction. So you're going to answer, I'm going to write them. That's all. If it's peptic ulcer due to increased acidity, the base of a peptic ulcer, will it be clear or will it have necrosis? Generally, the base of a peptic ulcer will be generally clear. Okay? It might have areas of hemorrhage, that's possible. Clear, the reason is the acid, like I said, is the one causing the ulcer. It will completely digest and destroy the tissue, right? It can have slight areas of punctate areas of hemorrhage, that's possible because it's an ulcer, it can definitely bleed, right? On the other hand, when I take tumor, any tumor for that matter can have necrosis, and this definitely will be necrotic ulcer, right? So they have a necrosis in the base because cancers divide fast. Whenever there's an increased cell division, obviously I'm going to have your necrosis in the base of the ulcer, and since there's no increased acidity, it will not clear the base as well. Fine, that's one. Okay, next. Uh, if you remember, as reading neoplasia chapter, or you must have seen in surgery as well, right? If you see a breast cancer, you might have palpated breast cancer patients during surgery postings. When will you call it as a cancer? When it's soft, firm, or hard? Obviously, you call it a cancer. You suspect it's a cancer when it's hard in consistency, right? The reason for this hardness is something concept of called as desmoplasia. We read long back in your neoplasia chapter. Any cancer can produce fibrous tissue. That's called as a desmoplastic reaction, right? Perfect, perfect. Great, Sadaf and meat, right? So now here, let's assume I'm having an ulcer here, okay? And just is your normal surface. That's an ulcer here. And here also, I'm having an ulcer, normal surface here. So like Meet said, and Osama, Meet, and Sadaf said, it's going to be hard or indurated, right? So what happens here is in this part, because of the desmoplasia, this is going to kind of become elevated. It's going to kind of become elevated, right? So if you have an elevated margins, in other words, I give a name called as heaped up margins. The heaped up margins is nothing but due to desmoplasia. I'm having lots and lots of fibrosis underneath, so the edge of it becomes much stronger, much thicker, right? If it's an oral ulcer, I can feel the desmoplasia, but it's a gastric ulcer, you cannot feel it, but you can see that's like a beaded margin. The margin looks beaded, the margin looks heaped up. On the other hand, since a gastric ulcer will not have desmoplasia, it's clear cut, right? It's just cut. So when you have a cut thing, what happens is, if I look at the normal rugosity, let's assume it's a three-dimensional structure. I cannot draw a three-dimensional structure here, but I have an ulcer here. It's completely cut, and the corners will have the rugosity radiating to it. So when I have rugosity or the corners, till the corners, if the rugosity reaches, that means there is no heaped up margin, right? So this is called as the rugosities or the gastric folds. You have them radiating from the ulcer crater. If it radiates from the ulcer's crater, which means there is no heaped up margin, which means there is no desmoplasia, most likely a benign lesion. This is a very important finding in an endoscopy as well as in a jarred specimen. If you have a heaped up margin, the folds of the gastric mucosa will not reach till the ulcer, right? So if it's this, let's assume this is the entire area of the ulcer. I'm having an ulcer here. The gastric folds will reach through this. This is what called as radiating from the ulcer crater, right? On the other hand, if it's a malignant ulcer, like I said, let's assume this is an ulcer. I'll have desmoplasia here. I'll have heaped up margin here. Okay. So which means the gastric mucosal fold cannot reach through the ulcer crater. That's a very important finding because desmoplasia is a hallmark of malignancy. This is required, right? Like Sadaf said, since it's ulcer due to acid secretion, it will most likely be sharp and it will be punched out. Okay? When punched out ulcer, because it's just destroying the tissue. And here, obviously, every cancer for us is going to be irregular lesion, right? Irregularity is definitely diagnostic of a cancer. Obviously, it will not be punched out, allow lots of infiltration happening, and it might be irregular as well, right? So these are few informations which help us to differentiate a benign versus a gastric ulcer. If it comes in a 2-mark question, don't miss these, and especially when it's a jarred specimen. And I'm sure you must have seen specimens of gastric ulcer for you. Whenever it's a jarred specimen, please don't jump into the diagnosis. Try to explain to them, and this is how it happens. There's a jarred specimen of a gastric, cut open gastric tissue where I have an ulcer in the lesser or the greater curvature. Try to comment on that. Then tell, okay, the margins look no heaping of margins, minimal heaping, looked punched out, and the mucosal folds are radiating from the crater. So most likely it's a benign gastric tissue. And always use this. End with saying, I need to take a biopsy to confirm, because gross is never confirmatory. I need to take a biopsy to confirm. That completes the description of any jarred specimen which comes in your viva. Fine. Okay, that's the starting point of a benign and a malignant gastric ulcer. Let's go to the second question you're going to read today. We're going to read about chronic gastritis. Fine. Okay, so when you go to read about chronic gastritis, before starting chronic gastritis, I just want to ask a very few questions, which if you can know the answer, just you can comment on the answer. First thing, is there any difference between peptic ulcer and gastritis? Are both same or are they different? Is it same or different? We'll start with an easy one. Peptic ulcer versus gastritis, same or different? Peptic ulcer versus gastritis, obviously both of them are very different thing, right? So if you have a question on peptic ulcer, which means it's due to their recurrent ulcers, various part of the GIT, major cause is due to acid and peptic juices, right? It's excess secretion of acid. That's what it is, right? Atrophy, maybe there may not be the meat, but the major thing here is it can be seen anywhere in the GIT, not just your stomach. I can see them in duodenum, especially when there's more amount of gastric secretion like Zollinger-Ellison syndrome. I can see them in the other parts of GIT as well, right? Anywhere in GIT, the reason for the ulcer is excess exposure of acid. So any disease which causes an excess acid secretion, I will think of an peptic ulcer. At the same time, when I call it as gastritis, gastritis is inflammation of the gastric mucosa. That's all. It's itis, right? It's just an inflamed gastric mucosa. It can be atrophic, like what Meet said. It can be acute gastritis. Stress can cause gastritis. I am sure during your before your university exam in the first year or even the second year, have you got after ulcers? You must have got after ulcer, right? So that also is an ulcer. It's also a part of GIT, right? So it's an inflamed gastric mucosa which can be eroded and can cause an ulcer due to any etiology. Fine. I'm coming to Jaffer, right? It can be due to any etiology. Okay. Jaffer, when I use the term erosive gastritis, right? It's a very superficial damage because when you take any ulcer at any part of the GIT, you will have the base. You must have described an ulcer when you were in your surgery postings, right? You'll have a margin, you'll have a base, and you'll have everything. So when you have everything like that, I call it a ulcer particularly. If it's an erosion, it's a very superficial damage. Erosive gastritis can happen due to subtle infections. Erosive gastritis can happen secondary to an shock or any hypovolemia where there's less blood supply. The top part can get eroded, right? That's called an erosive gastritis. It can happen due to peptic ulcer also. It's just superficial damage. Only the epithelium undergoing damage. I use term erosive gastritis. It is not entering your lamina propria or your submucosa and not forming a proper ulcer. That's the difference between it, right? Meet, is your question, can gastritis cause peptic ulcer? We look at them soon. Yes, some of them might, some of them might not. Because we have two types of chronic gastritis. That's what we're going to learn here. Right? We have one is your H. pylori induced, and we also have gastritis which can be autoimmune induced, autoimmune etiology, right? So we look at them and see that which part of gastritis will cause your peptic ulcer, if at all, if they cause a peptic ulcer, fine. Okay, so there's a difference between a peptic ulcer and a gastritis. Now let's go to the chronic gastritis per se. Like I said, when I say chronic gastritis, there are two common etiology, and these chronic gastritis are differentiated or classified as type A gastritis. Type A gastritis is of autoimmune etiology. Maybe you can remember as A for autoimmune, fine. And I do have type B gastritis, which is your chronic H. pylori gastritis, fine. It's H. pylori induced gastritis or an type B gastritis. Okay, fine. Okay, now I have two major causes. Now let's go one by one and see how actually this H. pylori causes gastritis. My main focus is chronic gastritis. They do cause an acute gastritis. We'll ignore that for time being. We'll cover the chronic gastritis, and if it's short-lived, I'm going to call it an acute erosive gastritis or an acute gastritis. Fine. We all know about H. pylori. If you remember H. pylori, what are the virulence factors which comes to you? Do you know any enzymes, anything of that sort? First, we look at your H. pylori gastritis because obviously that is a very important question for you. Do you know any virulence factor, any enzymes which is involved in the H. pylori? You must have. Perfect. Sahil, good. Urease. Any other virulence factor? Urease is definitely correct. There are many other virulence factor. One of them, important one of them is urease, right? I do have flagellin. H. pylori is a very slender S-shaped organism which can easily move. I do have flagellin. I have something called an adhesins, and there are few genetic components, and in addition to that, I have urease, right? So whenever you talk about any infection, be it in microbiology, be it in pathology, or be it in medicine, I want you to have a very classical template. Infection always starts with the root of infection. When I take COVID, inhalation, that's a root, right? So what is the root of infection in case of H. pylori? It's always your fecal-oral transmission, right? It's a fecal-oral transmission. That's the root for H. pylori. So when the fecal-oral transmission, the organism, H. pylori is a very slender S-shaped organism. So the slender S-shaped organism when it reaches your gastric tissue, there's one very important thing which easily can destroy the slender head-shaped organism. Can anyone tell me what's the first defense mechanism I have to destroy H. pylori? Obviously, the important defense mechanism for me is perfect, your acidity. The acid here can destroy H. pylori. Okay? It destroys H. pylori. At the same time, can I say if a patient has hypochlorhydria, that can kind of increase the division? Yes, obviously. So, which means if a patient has hypochlorhydria, which means there's reduced acidity, which kind of increases the risk of infection. Why I want you to remember this and why I want you to know this forever is when any person in your family member or you having a gastric pain, suspected gastritis, what's the first thing you do? What's the first treatment you get yourself? Do you go for antibiotics or investigation of H. pylori or you eat Gelusil or omeprazole? By default, what we do is we bring Gelusil or you put omeprazole. That reduces your gastric acidity. Actually, the drugs what you use to reduce actually going to help your H. pylori, right? Perfect. Right? It will definitely proton pump inhibitors will definitely increase the cell division of H. pylori, right? So let's assume in this manner the H. pylori came to your gastric mucosa. This is how the gastric mucosa is. Just for understanding, this is your epithelium of the gastric tissue. On top of this epithelium, you have a very thick layer of mucin. That's how it is, right? A very thick layer of mucin, and obviously have acid as well. Right? Acid as well as mucin is mixed with it. That's how it is. The acid as well as mucin. Okay. Now the H. pylori, first thing it reaches here. The most important thing about H. pylori pathogenesis, it has to get attached to the epithelium. Only then they can destroy it. So first thing is they swim through this epithelium and they get attached here, right? So they have a thick layer of acid and mucin here. They have to escape this and they have to swim through this. So the first virulence factor for me is flagellin. The flagellin or the flagellus component of the H. pylori helps to swim slowly and steadily and gets attached. And for this attachment, I need a second virulence factor of H. pylori, which is adhesin. It helps to adhere on the surface of the epithelium of the gastric mucosa, right? Now it's adhered. So once it's adhered, automatically the ones you guys said, urease, right? Obviously, urease will come to act. So when urease acts on the urea, right? So it's a urease, so it produces ammonia. When it produces ammonia, it elevates the gastric pH locally. It's not going to increase the gastric pH of throughout the stomach, right? So once it gets bound to it, then the urease acts, and the urease releases your ammonia, and the ammonia increases the local pH in the vicinity. That's all. Again, just for our perspective, let's assume there's the same stomach here, right? I'll just maybe draw this one alone, the acid mucin. This part alone, let's say it has been destroyed because H. pylori came here. The H. pylori bound to this mucosa and they produced urease and they kind of created an environment or a bubble for it to divide faster, right? Because if urease is going to increase the local pH and this bubble is definitely going to increase the H. pylori's division, because if the pH increases locally, there's no one to stop the division. It keeps on dividing. No acid. It's very fastly dividing thing. Because I think 20 minutes is the entire replication rate required for H. pylori, can divide like anything, right? So once it divides, when good amount of bacteria comes inside, right? It needs to have a sufficient amount. Every bacteria has a threshold for infection, right? Once a threshold for infection reaches, I'm going to get the cytotoxins here. Because H. pylori induced ulcers initially are inflammation induced ulcer. It is not an peptic ulcer initially, right? So what happens here is, so once they become a sufficient number, they get the fourth virulence factor. The third virulence factor obviously is an urease for us. The fourth virulence factor is a cytotoxin. So cytotoxin, we call it a CAG-A. Okay. So it's one of the commonest ones. Cytotoxin associated gene A is a CAG-A, and there's one more thing called VAC as well. CAG is important for me, right? So this cytotoxin, as the name says, it sells toxicity, right? So what it does is this will destroy the gastric epithelium. Destroys gastric epithelium, and obviously the bacteria enters inside. When the bacteria goes inside, okay, or into your subepithelial tissue, into the gastric tissue. A bacteria into the gastric tissue, will it cause inflammation? Yes, no. Obviously, it'll cause inflammation, right? So when it causes inflammation, it's going to result in your gastritis. This is an inflammatory induced ulcer. It's not a peptic ulcer, it's inflammation induced ulcer. Okay? This is very important. That's how H. pylori gastritis starts with. That's the starting point of H. pylori gastritis. Like I said, this might have been happened during your acute gastritis also. At recurrent gastritis also, I'm going to have this almost a similar finding one, right? This is how H. pylori gastritis starts. Now, our main concern is chronicity. So H. pylori has a very important location of infection. Can anyone tell me which is the most common site where H. pylori can damage the stomach? It damages predominantly the antrum, right? So now let's go to the chronic gastritis part. So if it becomes more and more chronic, what happens here is it's the same inflammation induced ulcer, the same cytotoxin, keep that in mind, but it's going to happen repeatedly in chronic. The most common location of H. pylori induced gastritis is antrum. Yeah, antral predominant gastritis. On the other hand, the other one, the autoimmune gastritis and body predominant gastritis. Great, Jason, right? It's an antral predominant. So here in the antrum, repeatedly I'm having destruction. Let's try to draw it. Okay, it's repeatedly destroying it again and again and again. If there's repeated inflammation, can I say it will destroy the entire mucosa, or can I call it an atrophic gastritis? Like Meet was saying, if it's an antral predominant gastritis and if it is repetitive, obviously it will cause atrophy of gastric mucosa. So it will cause an atrophy of gastric mucosa. That's one thing here. It's an atrophic gastritis. So now, if I'm having an atrophic gastritis, I'm just going to ask you one question. It's a very simple question. I want you to answer. The antrum, entire mucosa is going to get atrophied. So what happens is, can I say when antral mucosa is atrophied, the cells, the gastric cells, the chief cells, everything also will be damaged in that mucosa? Am I right in saying that? Yes. So when this happens, when there's an atrophy of gastric mucosa, it reduces your chief cells, it reduces your parietal cells and everything. In other words, this will actually reduce your acid secretion. So this acid secretion, if it's reduced, less acidity in the stomach, what neuroendocrine cell or what hormone will be stimulated? There's a GI or hormone which will increase in response to that. What is that? What's the GI hormone which will increase in response to it? Perfect. It increases your gastrin. Perfect, right? This reduced acid secretion will increase gastrin. So gastrin or the G cells, when it's increased, perfect Meet. So this will increase acid. It's a feedback mechanism, that's all. Whenever it's reduced, it automatically increases. That's what happens. And this increased acid secretion, can it cause peptic ulcer? Coming back to your question, mate, you asked that can an H. pylori induced gastritis cause peptic ulcer? The answer is yes, it can cause peptic ulcer, right? So there is a risk of peptic ulcer as well. But like I said, peptic ulcer is an effect of H. pylori gastritis. Peptic ulcer happens, may not happen. Can be an acute gastritis, it can have peptic ulcer as well. At the same time, let's assume it's a chronicity. More and more and more chronic, repetitive reactooxin species, repetitive damage, can it result in the mutation? Or will reactooxin species cause mutation? Obviously it will, right? There's an increased destruction due to your reactooxin species, and reactooxin species can cause mutation. So when you have mutation, it obviously can result in an increase the risk of adenocarcinoma. That's obviously present, right? Next is a chronic repetitive H. pylori gastritis. So obviously when there's a chronic repetitive H. pylori gastritis, there'll be increased B lymphocytes because I need to produce antibody against the bacteria. Again, every now and then it's getting stimulated, right? That increases the risk of maltomas. I think Jason told all these things at the start itself, right? It can cause gastritis, it can cause peptic ulcer, it can increase the risk of adenocarcinoma, it can increase the risk of maltoma. This is what happens in your chronic H. pylori gastritis, right? The reason why I have this feedback mechanism is it's an antral predominant gastritis, right? That's your type B chronic gastritis or H. pylori induced gastritis, right? Now let's look at the other one. The other one is your type A or an autoimmune gastritis, fine. The second type of chronic gastritis is your type A gastritis or an autoimmune gastritis. We'll not go into the exact complete etiopathogens of autoimmune gastritis, but I'm sure that most of you know that why an autoimmune gastritis happens, and it's also called as a pernicious anemia, right? Meet why maltoma. Okay, let's assume that I'm having a H. pylori infection today. My B cells are getting stimulated, and the B cells produces an antibody. After a month, I have one more episode of H. pylori, chronic. After 3 months, again. After 6 months, again. After 8 months, again. So repeatedly, I'll have stimulation of the B lymphocyte, right? The memory B cell, in other words. When I stimulate anything repeatedly, there's a possibility during the division of the B cells, one of them can have a mutation and go into maltoma. For any autoimmune disorder or for any repetitive infection, maltoma is a long-term complication. For example, Hashimoto's can cause maltoma. Repeated destruction of the thyroid. Sjogren's can cause maltoma. Repeated destruction of your salivary gland, lacrimal gland, everything. Right? Perfect. Let's go to your autoimmune gastritis. Great, Jason. It's called as pernicious anemia. Fine. Let's go to pernicious anemia. Before going to pernicious anemia, first of all, I want you to remember that pernicious anemia, though whatever comes to your mind, the antibodies to parietal cells is the first thing which comes to your mind. It is not a type 2 hypersensitivity. I'll tell you what exactly happens. In pernicious anemia, the pathogenesis, I want you to listen carefully. Please listen. Otherwise, you might miss maybe whenever an MCQ point comes. Initially, it's in CD4 T cell mediated destruction or damage to your gastric epithelium. Okay, it damages to your parietal cells. That's how it damages, right? When it's a T cell mediated damage, it's a type 2 hypersensitivity or type 4 hypersensitivity. What do you think it is? Type 2 or type 4? If it's cell mediated, it's type 4 hypersensitivity, right? It's not type 2, it is type 4. Please don't jump and write type 2 just because you, whatever comes to your mind when you think of pernicious, antibodies to parietal cell, right? So this is the damage first happens. So when the parietal cell damage happens, the T cell can get destroyed. The T cell can destroy your hydrogen potassium ATPase. The T cell can destroy your entire parietal cell or a part of the parietal cell, right? So whenever this damage happens, the response creates a new antigen. This we have learned a lots of time. Whenever a cell is destroyed, pencil is destroyed, I'll have new antigen. So here, in response to the T cell mediated destruction, my body starts producing autoantibodies. This produces autoantibodies. Like you already know, I can have autoantibody against the parietal cell, intrinsic factor, or I can have the autoantibodies against your hydrogen potassium ATPase, right? So I can have autoantibodies against your intrinsic factor or against your parietal cells or against your hydrogen potassium ATPase. Anything can form the autoantibody, right? So once I'm going to have no, Jason, pernicious is not type 2. That's what I said, that if you're going to read superficially, it looks type 2. Type 2 is a response. Type 4 is the cause. Okay. If a question says a mixture of type 2 and type 4, like me, it says, yes, I'm okay with it. But what happens is it starts like this. Its response here, yes, this response, the antibody also causes damage. But the starting etiopathogenesis is always a type 4 hypersensitivity. Later on, type 2 hypersensitivity gets an upper hand, right? Most of us miss this. We jump into type 2 because we ignore the type 4 first, right? Okay, I hope it's clear. Okay. Fine. Now let's look at this. Okay, great. So now I have an antibody here. This antibody is going to destroy all the parietal cells intrinsic factor. It's a body predominant gastritis. It destroys the entire mucosa in the, it's not the antral predominant like your H. pylori, it's a body predominant gastritis, right? So I'm going to have destruction due to an autoimmune pathogenesis. Then those neutrophils, right? So which inflammatory cell you will see here? What inflammatory cell you will see here? You will see predominantly lymphocytes, right? Any autoimmune disorder, it's going to be lymphocytes in microscopy, not neutrophils in microscopy, because lymphocyte is the one which destroys the entire body, entire parietal cells, everything, right? So here also I'll have a reduced acid secretion. So whenever there's a reduced acid secretion, what is my body's response? It produces increased gastrin, like we already saw. This is a body predominant gastritis and it's not patchy. The entire gastric mucosa will be destroyed. It causes an pan gastritis or pan atrophy. The entire gastric mucosa will be destroyed. It will not going to spare anything. Chief cells, parietal cells, everything will be destroyed because lymphocytes are very, very powerful because chief cells and parietal cells are very close to each other. So once they destroy this, that also will be destroyed. It's a pan gastritis, an entire atrophy will happen, right? So if gastrin increases, let's assume this should increase my cells or the gastric secretion, right? So let's assume this increases the acid secreting cells. So the acid secreting cells increases. The antibody what we already have, the hydrogen potassium ATPase, will it let them survive or it will kill them also? What do you think? Will it let them survive or it will kill them again? When the acid producing cells comes, the antibodies will destroy them immediately. So in other words, when gastrin increases, my body should respond by producing more acid. For that, I have the cell, but the antibody destroys it again. So do you think acid secretion will be more or still it will be reduced? Still cause even more, again, reduced acid secretion. What I'm trying to tell here is, in other words, will this patient have a risk of peptic ulcer? Will they have peptic ulcer or not? No peptic ulcer, right? There'll be no peptic ulcer. That's one main difference between this and your H. pylori induced gastritis. H. pylori had peptic ulcer because patchy atrophy, patchy destruction. So whenever gastrin increased, the cells increased, produced more acid. But here the cells increase, but the antibody destroys the cells, will not be able to produce more acid. And if acid is reduced, what happens again is I'll have more gastrin secretion. It's like a vicious cycle, right? Now I want you guys to think and comment here. My acid secrete atrophy was there, more gastrin, not able to secrete acid, again more gastrin. So is there a possibility that G cells or the gastrin secreting cells in this patient will have n amount of hyperplasia or more and more and more division? Possible? Definitely possible, right? Good evening, RN. If that is possible, can I say this patient has a risk of gastrinoma or neuroendocrine tumors of your GIT? Right? Because of excessive gastrin secretion, the sequelae of your autoimmune gastritis, there's extremely high G cell hyperplasias, which might increase the risk of neuroendocrine tumor. I can call it an carcinoid, I can call it an gastrinoma, whatever I want to call it, there'll be an increased risk. There's no increased risk of peptic ulcer. At the same time, there is meat just is arising from your interstitial cells of Kayal, right? It's a pacemaker. I'm talking about a neuroendocrine cell here. That's a G cell. So I'll have carcinoid tumors of that part. Fine. Since parietal cell is destroyed, one of the important sequelae, that's where we started with, they can have pernicious anemia because I need parietal cells for my intrinsic factor. So there's reduced B12 absorption. That can be a sequelae here. At same time, it's inflammation induced. I'm going to have definitely more reactive species. Whenever there's more reactive species, automatically it will destroy all your cells, more mutations. There's a slight increase in risk of adenocarcinoma as well. Whenever you talk about any autoimmune disorder, I want you to start in the clinical features as a pointer. Autoimmune disorder never comes alone because when a patient has an autoimmune disorder, the person's immune system is considering some part of the body foreign. Let's assume here gastric tissue foreign. So the immune system is at fault. So can I say for sure this patient's sometimes down the road or previously the same immune system must have seen the thyroid foreign or the salivary gland foreign? Yes, right? The association for almost every autoimmune disorder, they will be associated with other autoimmune disorder like Hashimoto's. They can be a part and parcel or maybe in the past history or the future, right? Or I can have Sjogren's or I can have SLE because no autoimmune disorder comes as a single thing. Once it is there, the entire immune system is at fault, so I can destroy other parts of the body as well. It's most of the time associated with these, fine? So that's about the chronic gastritis, your H. pylori induced gastritis, and your autoimmune gastritis, fine? Okay. Now we know we are done with the second half of today's discussion. The third discussion here is about your gluten sensitive enteropathy. What's the other name? You know the name. That is celiac disease, right? Celiac sprue or celiac disease, whatever you want to call it. I have something called a tropical sprue. We'll look at tropical sprue also maybe sometimes a little bit later, but it's more of a celiac disease, fine? Okay. Celiac disease, I'm sure everyone knows about celiac disease. It's due to gluten sensitive hypersensitivity, right? Before going to celiac disease, I want to add a little bit more understanding of why the celiac disease exactly came and what is the reason why the body is destroying gliadin or body is destroying enterocytes, right? Uh, Great. Meat. When I say uh, which cell produces your pepsinogen. Pepsin is produced by chief cells, right? So I might have a little bit of secretion of the chief cells because pepsin is produced by the chief cells. Chief cells might be there in the scattered part of the body. Pepsin comes. So my protein absorption is not that affected. That's one part. Second, the protein absorption to happen, can I say pancreatic proteases can also help? Pancreatic protease can definitely help, right? It will definitely help. So you take iron, when iron is absorbed in the duodenum, so it's not absorbed in the stomach. For iron, I need the duodenal cytochrome to be present, the DMT1 in the duodenal epithelium to be present. If it's there, the iron absorption happens normally. The acidity change might reduce iron absorption, but not nullify it or not make it zero for sure. Fine. I hope that clears it out. Let's come to celiac disease. The celiac disease, you have it's a gluten sensitive enteropathy, or we call it a celiac disease. It's about sensitivity to your bro foods. Bro stands for your barley, rye, oats, and wheat. Okay. So what happened is celiac disease. The origin is whenever uh, wheat is where celiac disease originated. So when Indians are the largest consumer of wheat, when we went abroad, we took our food outside. Obviously, unfortunately or fortunately, our food is tastier than any food in the world, right? So when an European started eating my food, their body couldn't digest it because their body doesn't know how to take care of wheat. That's the actual origin of celiac disease. In other words, the celiac disease incidence in India is very, very rare compared to in Western population. It said that 15 to 20% of the Europeans are at risk of celiac disease. The reason is their body doesn't know how to digest it. In other words, the genetics is a bit different. So celiac disease, one of the major risk factor is your genetics. And in genetics, I have two HLA molecules, HLA DQ2 or DQ8. Okay. So this HLA molecule is the one which triggers the activity against gluten. So if this HLA molecule is not there, the sensitivity to gluten or celiac disease is very, very, very low. Right. So let's understand what happens to a normal person's gluten, like you and me, who doesn't have this HLA DQ2 DQ8. Then we'll also understand what happens to the gluten when the person has this HLA DQ2 and DQ8. Right. So normally, without these thing, let's assume I'm consuming gluten. Gluten is seen in wheat, chapatis, most of the wheat containing food has gluten. It goes into my intestine. My intestine has an enzyme called TTG. Can anyone tell me what TTG is? TTG stands for tissue transglutaminase, right? Obviously, you know that, right? So, with the help of gluten and with the help of tissue transglutaminase, gluten is one of the byproduct is gliadin, right? It's a byproduct of gluten called gliadin. With the help of TTG, it becomes something called a deamidated gliadin. It's a chemical chain, that's all, right? It's a deamidated gliadin. So for you and me, my body knows for a fact that I cannot absorb gliadin because gliadin is a dietary fiber. Any dietary fiber I cannot absorb, so I'm going to excrete them, right? So in normal patient, this gliadin will be deamidated gliadin or gliadin will be excreted because my genetics knows that I don't want to digest them. It's a dietary fiber of the wheat or the oat or barley or rye. I'm going to push it outside. I won't absorb them. I won't interact with them at all. I'll leave that. So if a person has HLA DQ2 and DQ8, the body reacts a bit differently. Okay? The same HLA molecule, the body slightly reacts a bit differently. Fine. Let's assume the same thing. It's a gluten and the gliadin in a person with a HLA molecule. With the HLA molecule and with your tissue transglutaminase. TTG stands for your enzyme tissue transglutaminase. With the help of this enzyme, what happens is the deamidated gliadin is formed. My body will consider them as an antigen because I don't know what to do with that because it's newly exposed to me, right? So this will be taken up by your antigen presenting cells or your macrophages. The APCs in the gut will eat them. Ideally, I should have excreted, but since I have this HLA molecule, APCs have MHC molecule is nothing but your HLA, right? So if it's HLA DQ2 DQ8 is present, it binds to the deamidated gliadin and swallows them. And this presents to your T lymphocytes. So in CD4 T cells identifies the deamidated gliadin. Again, in those people who are sensitive, it's considered foreign, and this T cell reacts and the T cell gets activated, it produces inflammation, and this destroys enterocytes. Again, what type of hypersensitivity is this? Can anyone comment on that? The T cell is the one which is primarily destroying everything, right? That's the one which destroys everything. That's the starting point, obviously. So this is obviously a type 4 hypersensitivity. Every type 4 hypersensitivity, whenever the CDT4 4 is getting elevated, it will automatically, other name is T helper cells, right? They'll help your B cells to produce antibody. See, this is what exactly happens in celiac disease. So my body has to protect. That's the function of the body. So what the body does is, let me produce antibodies against this guy, TTG, so that I won't have the problem. Let me produce antibody to gliadin. I bind to gliadin, I destroy them before the APC takes it, right? So when I have this destruction, as an effect again, as a response again, not as the cause. They're two different things. We have learned the same pathogenesis almost in both your pernicious anemia and here. It's an effect, it's not the cause. As an effect, so what happens here is I'll have an antibodies to TTG. The B lymphocytes produce them. I'll have antibodies to your gliadin. And this TTG cross reacts with one more protein in the body. I have antibodies against endomysium. The antibodies against this. So this is an effect. So when this is produced, the TTG is destroyed, gliadin is destroyed, no deamidated gliadin, T cells reaction becomes less, the celiac disease stops. That's the waxing and waning cause of any celiac disease. That's how it happens. Again, if the person eats gluten, one more reaction, it stops, right? That's the entire pathogenic spectrum of celiac disease or your gluten sensitive heart and your enteropathy. Now here, I'm having destroyed enterocytes. If the enterocytes are destroyed, my intestine is not able to absorb things. So ends up in having malabsorption diarrhea. It causes us malabsorption diarrhea. Okay, Nana Pot, I'll answer your question. Nana about why endomysium is, like I said, TTG has a molecular mimicry with endomysium. You must have heard about the concept of molecular mimicry in your rheumatic heart disease, right? So what happens is TTG and endomysium, more or less protein structure is similar. So when my body produces antibodies against TTG, since half of them or 75% of them overlap, that antibody can also go and bind to endomysium and start destroying them. So it results in endomysial antibody. I hope you get that. Fine. Means not everything, most of the type 4 hypersensitivity will have a type 2 association. That is true. Most of them true. Like for example, type 1 diabetes is type 4 hypersensitivity. I have antibodies called as anti-GAD antibodies. Hashimoto's thyroiditis, you must have read. Type 4 hypersensitivity. And antibodies called as anti-thyroid peroxidase antibody, TPO antibodies. Not the reverse is true. Type 2, like example, autoimmune hemolytic anemia is type 2. Good pasture is type 2. They have no risk with type 4. But most of the type 4, yes, they will be followed by type 2 hypersensitivity. Most of the time. Not always, most of the time. Fine. Let's go back to this. So I'm going to have a malabsorption diarrhea. The symptomatology is simple. So I know the pathogenesis. To create an university exam paper have sections. Etiology, bro foods. Pathogenesis, we know. Symptomatology, again, a age group. Most of the autoimmune disorder happens in mid, right? It's an age group around, let's say, 30 to 40 years of age. Most of the autoimmune disorders is little bit more common in women. Women are more predisposed to it, and it's more common in foreign countries. It's most of an European or an Caucasian disorder. In India, it is rare. You can write for sure it's India is rare. It's very, very rare in our country, right? And here, the patient will have malabsorption diarrhea. There's no absorption at all. So the patient might also have flatulence, distended abdomen feel. That's very, very common, right? Flatulence, right? The gas forming, and also very important thing, skin lesions. Please underline them if you're writing an university exam, because like I said, TTG cross reacts with endomysium. The same TTG also cross reacts with a tissue protein in the skin called as an anchoring filaments. Because of that, the patient with celiac disease can present skin lesions called as dermatitis herpetiformis. Just add on to this, I have a disease called as dermatitis herpetiformis. So this dermatitis herpetiformis can happen because antibodies to TTG cross reacts and destroys dermal proteins. Okay, it destroys dermal antigen, so automatically the patient can have skin lesion, dermatitis herpetiformis, right? So I have a very good spectrum. It's related to your GIT, and also I have a skin infection classically, right? Skin inflammation classically. So then I obviously have to come to the diagnosis. Diagnosis of any autoimmune disorder is based on serology. Serology obviously is the gold standard one for diagnosis. You use the same TTG, endomysial antibodies, that's diagnostic. In addition to that, you also have biopsies, right? It's definitely not must. Biopsy is not must to diagnose celiac for sure. Yes, I do have biopsy findings, but it's not must to diagnose celiac. The T cells destroyed enterocytes. Enterocytes is in the form of a villi. The villi will be destroyed. The first finding for me is villus atrophy. The villi undergoes atrophy, the villi are being destroyed. That's the first finding. Second for me, if you remember in your first year, you must have drawn villi like this, and there'll be downward projections. What are these downward projections called as? What do you call them? The upward projection is your villi, downward projection is your crypt, right? So the crypt also will be destroyed. So the crypt will have hyperplasia, because once villi is destroyed, my crypt compensates for the villi and produces, because the crypt has stem cells. That's one of the cells present in the crypt. There are many more cells, but stem cells are present in the crypt. When the villi is gone, the stem cells contribute to them, so it have perfect energy. I'll have crypt hyperplasia. And all these were due to lymphocytes. So in microscopy, I also have a dense lymphoplasmacytic infiltration in your lamina propria of the mucosa, because the villi was destroyed by lymphocytes. I'll see them as well as crypt hyperplasia also will be seen. Again, like I said, biopsy is not must for celiac disease. And if you want to end the thing with treatment, stopping the bro foods is a treatment. Stop gluten sensitive foods, gluten containing foods. You stop that, automatically the entire pathogenesis over the period of time will reduce. Always is good, if there is a complication, write the complication of the disease. Again, that completes the entire thing. Let's assume a patient is not diagnosed with celiac disease. He or she doesn't know they have celiac disease. If they don't know they have celiac disease and they keep on eating the gluten-free foods, they have diarrhea, it's fine. They think that okay, it's part and parcel of their life. They keep on eating it. So there's a chronic stimulation of T cells. If there's a chronic stimulation of T cells, what's the risk factor? They can have a very aggressive lymphoma called as an enteropathy associated T cell lymphoma. This is very, very common in a chronic untreated case of celiac disease. Is a very aggressive lymphoma as well. Right? It's a very aggressive lymphoma, which happens only when the patient keeps on consuming without stopping bro food. If the person is stopping bro food, not consuming, this risk is almost nil. Fine. Now let's look at the microscopic image. If you want to draw an image, yes, you can easily draw an image. This is your normal biopsy. Can you see the villi? Finger-like projections. As a beautiful villi, right? Amazing villi. I just mark one more cell. If any one of you knows that, tell me what cell that is. I'm sure you know that. Name this cell. What cell do you think this is? What is cell? Anyone? That's your classical. Come on, I'm sure you guys know that. Clear areas in your intestine. That's a classical goblet cell, right? Perfect. Okay, that's in goblet cell. And you can see here, again, this is your normal crypt. Crypts are always very, very small. That's a normal crypt. Very good, Dana. Right? I have crypt and I have villi. So compare this image to this. This is your celiac disease. Okay? This is celiac disease. Is there any crypt? Sorry, is there any villi? No villi. There's no upward projection at all. The entire villi is flat. That's the first finding. I have villus atrophy. The second thing here is, if you look at this place in between the glands, I have lots and lots and lots of small round blue cells, right? I have lots of small round blue cells. That's your lymphocytes. I have lots of small round blue cells. You have lymphocytes and villus atrophy. Maybe in this image, I'm not seeing a crypt hyperplasia, but a crypt hyperplasia is a finding seen in celiac disease, right? So you can draw a normal, put an arrow mark, and write celiac disease, villi gone, crypt becoming very deep, and lots of small round blue cell in between them. That's how you describe a celiac disease, right? And the third question of today, right? Let's go to the fourth one, next one. Let's talk about IBD. Because IBD can come as a long answer question. It's definitely potential for a long answer question because that's a very classical clinical symptom. And middle-aged person with diarrhea, dysentery, altered bowel habits, plus or minus vitamin and malabsorption, think of an inflammatory bowel disease, right? The history of a middle-aged person with diarrhea, dysentery, okay, and less or minus mucus in the stools. This patient will have a very chronic history, repeated history, right? With history in the past, history of similar episodes in the past. This is very important for me to identify it's a chronic disorder because diarrhea, dysentery, and mucus can be seen in your Shigella. That also can happen, or an enterohemorrhagic E. coli can happen. With similar episodes in the past, right? You think of an or suspect an IBD. IBD is a very important and a potential long answer question, right? So if you look at IBD, Crohn's and ulcerative colitis are a bit difficult to remember if you don't approach in the right way. So what you're going to do is we're going to learn the same table what is given in Robbins. There's a table in Robbins that's actually very good. The only thing is about a table is you read a table, you forget it very quickly, right? So we're going to see the same table in the Robbins, the same features, almost every feature, but in a very unique way. We know about the names, ulcerative colitis and Crohn's disease, and both of them are chronic inflammation. We already are experts of chronic inflammation. With that simple knowledge, we'll try to understand many things about your ulcerative colitis and Crohn's disease, right? So both of them, let's draw a table. We'll also draw the table, but in a very different way. I just want you to remember Crohn's disease, it's ulcerative colitis. The only thing which I want you to remember in both the name, obviously, that Crohn's is transmural inflammation. Ulcerative is superficial mucosal inflammation. It will not involve the entire thickness. Transmural means it involves the entire thickness. Here, it will not involve the entire thickness. Fine. Perfect. So, if you have the table in Robbins, open that. We'll take one by one with a very simple logic of these two. That's all. I just want you to remember the name, and I just want you to remember one is transmural, other is superficial mucosal. Fine. Which of these two do you think will involve only colon? It's there in the name. Colitis, right? It involves colon only. It involves only colon. On the other hand, your Crohn's disease involves from oral cavity to anal canal. It involves the entire segment of GIT. The distribution is very vast. I can have oral lesions till your anal canal. If this is true, let's extrapolate to the next point with the same thing. One disease is very extensive, oral cavity to anal canal. Other is colon only. Which of these two do you think will have skip lesions? Can I say a patient with Crohn's disease cannot survive even a single day Without skip lesion, entire GIT is inflamed, can't live, right? So obviously, since the disease is very, very extensive, they need to have skip lesions. It's a very extensive disease, so skip lesions are must. It's must to have this. This one is a very limited disease, only colon, so it can be continuous. Because I can fairly say that even after removal of the colon, the patient can survive, right? Continuous or it is diffuse. They don't have a skip lesion. Generally, they don't have a skip lesion. Fine. Both of them are chronic disorder. Chronic disease, chronic inflammations, hallmark is tissue destruction and healing by fibrosis, right? Let's assume ulcerative colitis and Crohn's disease will have both tissue destruction, healing by fibrosis, fine? Let's assume this is lumen. Crohn's disease is transmural. I'm writing TDHF for tissue destruction, healing by fibrosis. So in both of them have tissue destruction, healing by fibrosis. It's a transmural destruction. So can I have fistulas, fissures? If it's destroyed transmurally, I can have fistulas, I can have fissures, I can have sinuses. Possible. Entire thickness is destroyed. At the same time, heals by fibrosis, right? We'll have stricture. We'll have stricture. That's a part and parcel of it. If there's a stricture, the bowel becomes thick. Obviously, the bowel becomes thick because it's fibrotic bowel, transmurally fibrous bowel. On the other hand, ulcerative colitis is a very superficial, only the mucosa is gone. So I won't have a thick bowel at all, right? It's a very superficial inflammation. If it's a superficial inflammation, let's try to draw a bowel just for understanding. Let's assume this is your villi because it's colon and I have your muscle. If I am having an ulcerative colitis, I'm going to have destruction of the villi superficially, throughout gone, destroyed. Again, just for understanding, nothing has happened to my muscle. Muscularis is completely normal, right? So now here, if you have to compare the ulcerated area to the normal area, okay, look at this. I'm having an ulcer here, right? I'm having an ulcer here, and I'm having a normal mucosa here. So when I look at the ulcer and the normal mucosa is looking very big next to an ulcer when I compare, right? So here, this is the ulcerated area, which is very, very tiny adjacent to a normal mucosa. So this normal mucosa at the edge of the ulcer looks like a projection. Yes. So you call it a polyp. Anything projecting from skin or mucosa is called as polyp. This is actually not a polyp. We call it a pseudo polyp. We call it pseudo polyp. Pseudo polyp means it's nothing but an normal mucosa at the edge of an ulcer. Okay, that's pseudopolyps. Normal mucosa at the edge of the ulcer. That's a classical pseudopolyp, right? We know that as well. If you look at this image itself, I can go to the next point. Ulcerative colitis are more broad-based ulcer. If you look at the Crohn's disease, again you can compare that. Crohn's disease, this was a bowel, right? This was a lumen, and the ulcer was going so deep, right? It's transmural, right? So these ulcers are very deep, knife-like ulcers. It cuts through and through, right? Let's assume how it will look like. Again, let's assume this is a segment of bowel. If it's a superficial broad-based ulcer, it looks like this. The entire bowel superficially is gone, fine. If it's a deep knife-like ulcer, right, it looks like this. Let's say it looks deep, it looks deep, it looks deep. It's cut deep. This cut, the deep knife-like ulcer cut, have you seen pav bhaji buns? Yeah, like kind of looks like that, right? If I look from the top, it's completely cut till the edge, right? So this, for the person who first saw, for him or her, it looked like an cobblestone mucosa. As a classical finding, cobblestone mucosa is a classical finding seen in case of Crohn's disease and ulcerative colitis is a very broad-based ulcer, right? I'll just show you an image. That's a cobblestone mucosa. Maybe we should have named it Pav Bhaji Pan, right? It's a cobblestone mucosa. It's extremely deep and cut. Looks like a cobblestone, fine? Okay, we know that as well. Let's go to the next point. Like I said, we already read that Crohn's disease is going to involve the entire thickness of the bowel. Ulcerative colitis superficial only. So which of these do you think will have fat vitamin malabsorption? This obviously. So malabsorption here will obviously be more of fat or vitamin, fat soluble vitamins and fat malabsorption. Here it's no, it's not C. Maybe I can have water malabsorption because the only thing the colon is going to reabsorb is water. Fine, that I can see here. Fine. Again, perianal fistula, anything in fissure fistula is common with your Crohn's disease, not seen in your ulcerative colitis. Fine. Next, ulcerative colitis. When you look at the pathogenesis, it's predominantly Th1 related. Crohn's disease. Ulcerative colitis, on the other hand, it's Th17 related. This actually dictates your microscopy. If you remember in chronic inflammation, when we discuss about TB, good evening, Anjana. When we discuss about tuberculosis, you have Th1 activation, right? Then tuberculosis in microscopy, I had granuloma. So whenever Th1 is activated, it automatically ends up in a granuloma formation that is seen in case of an Crohn's disease. And obviously, there'll be a very, very excessive lymphocyte reaction. It will have, because in granuloma, if you remember, in the center you have the epithelial cells surrounded by lymphocytes. It's because of Th1 related. Th17 is very unique. It causes acute on chronic inflammation. That's wherever you see Th17, you'll have acute or chronic inflammation, which means I'll have neutrophils plus lymphocytes. I'm not saying that lymphocytes will not be there. Neutrophils plus lymphocytes, I won't see granuloma because acute on chronic, right? You'll have neutrophils, and the neutrophils which is seen in the bowel, we use the term crypt abscess. I'm sure you must have heard this. Yeah, crypt abscess here and here. Lymphocytes will be there, but lymphocyte infiltration will be moderate, not marked. It will be there, but not as much as your Crohn's disease, because acute on chronic inflammation. Fine, that's how it happens. Fine. So both of them are chronic disorder. When both of them are chronic disorder, over the period of years, repeated destruction, repeated reactive oxygen species induce damage, which can cause mutation. So both of them has a complication of colonic adenocarcinomas. It's common for both. Both of them will have risk of colonic adenocarcinomas. One finding is very common in ulcerative colitis, a complication called as toxic megacolon. It's an enlarged colon because ulcerative colitis has a tendency to destroy neural plexus. If they destroy neural plexus, that's your mesenteric plexus, obviously ends up in having your megacolon. That's not seen in case of Crohn's disease, right? It's a very simple description. Whatever we already know with inflammation and the normal function of the bowel, we can extrapolate and learn whatever is required, right? So that's your cobblestone mucosa. You can draw this descriptively in an image, just deep knife-like ulcers, right? This is also a very important finding. We'll learn this as well. Let's assume it's a cut surface of a bowel. Again, for understanding, lumen. I'm sure you must have read about mesentery. In your first year, you must have called mesentery or omentum as a policeman of abdomen, right? That's what you must have called. So here also I have a mesentery on the side. The function of mesentery is, apart from giving blood supply, the other function of mesentery is, if a bowel is about to have a rupture, impending rupture, mesentery goes and covers the area. That's why I call it policeman, right? So here, since it is Crohn's disease, transmural, there's a chance it can have fistulas and fissure, right? So what this mesentery does is, mesentery comes and covers the area. It comes and covers, so it calls an creeping pad of fat. Okay? It's a creeping pad of fat. That's again diagnostic of Crohn's disease because of the transmural inflammation. You can look at this. There's a fat here or the mesentery here. If you look at this part on the horizontal area, it's moving here. That's called a fat wrapping the entire ball, or I call it a creeping part of fat. Both means one and the same. Fine. Okay. And this is nothing but your crypt. You can see the WBCs inside the crypt. That's how your crypt abscess looks like. Okay. Crypts are downward elongations. When I have a cut surface, this is how we draw villi and we draw crypts, like villi and crypts. So if I cut the crypt like this, that's how I take a section in pathology. It looks round. So all these round glands in an intestinal biopsy I call it a crypt. And the entire, all these three crypts here are having WBC inside them, and we call it a crypt abscess. Again, it's more common in ulcerative colitis and little bit rarely seen in Crohn's disease as well, right? Okay. And then an enhanced image of how a pseudo polyp looks. Just zoom this. Beautiful image, right? In this entire part of the bowel, this entire part is completely ulcerated. Nothing is seen, no mucosa is seen. Maybe here, the mucosa is left out, overhanging mucosa, overhanging mucosa. All these places where the mucosa looks like overhanging, because of the background ulcer, it looks like a polyp, but it's not a polyp, it's a normal overhanging mucosa. So we call it an, perfect, we use the term pseudo polyp. They call it a pseudo polyp. It's more again common in ulcerative colitis because of superficial mucosal inflammation. Great. So that brings us to the end of the GIT part 2. I should have covered this in the GIT along with the part 1. So I was not able to cover it. So we saw about benign gastric ulcers, malignant gastric ulcers. We saw about H. pylori gastritis, autoimmune gastritis. We saw about celiac disease. And also we had quick discussion on your inflammatory bowel disease, ulcerative colitis and Crohn's also, right? So if you are first time here and if you just give me a second. If you're here for the first time and if you're not downloaded your FARRE notebooks, which is in the PW app, which is free for all the second year students, just go and have a look at the FARRE books, and I hope it should help you in clearing your university exam. It's a very short thing. So in all the lectures, what we have, we are trying to cover most of them. There are some of the questions that are left for you. Please go and have a look at them. They are a compilation of previous 10 years of university exam questions. So if it helps you in your university exam, that's the best thing what we can do, fine. So thank you for your time. Thank you for your patient listening. See you soon in the next coming little bit of more lectures of pathology is left. A few of the students have texted on discussing the gross specimens. I'll definitely book a class for that. We'll do the gross specimens as well. And let's see if we can learn more together, fine. Thank you for your time. See you soon. Till then, bye-bye.